Hi, everybody. This is Tracy Morton at the National Rural Health Resource Center. I'm standing in for Caleb Syme today, who is traveling back to Minnesota from visiting a small rural hospital in Utah. So thanks so much for joining us today for the second to the last session for the Learning Collaborative in the 201 series. So thanks so much for being part of this. A couple more folks might jump on the call today as we proceed, but I wanted to give you some updates that Caleb asked that I provide in advance to remind you about some things that are coming up and some final to-dos as being part of this Learning Collaborative. So like I mentioned, we have one more session that's next week, and you all have kind of an assignment to do as being part of the Learning Collaborative, and that's to take the information that you've been hearing over the last 4, now today with 5 webinars, and develop an action plan. What we'd really like you to do is take some of the things that you've heard about, that you've learned about, and incorporate them into the work that you're doing. So this doesn't have to be some brand new, big, giant project that needs lots of funding and things like that that may not exist, or lots of time that also may not exist, but some things that you can do to either tweak what you have planned maybe for this next program year in your flex work or your ship work or even your SOAR work, or activities that you are wrapping up this year, or just other initiatives and conversations with partners, et cetera, within your state. So we ask that you develop an action plan about taking some of the things that you've learned and putting them into practice. This is a way for us to evaluate the success of the time that's put into this training, but it's also a way for you to really take the information and move from just the level of understanding the content to really being able to apply it. So Caleb and Andy have placed into the SharePoint site a template of the action plan. So if you haven't taken a peek at that, please look at that. I know Andy also emailed it out, but it's there existing in the SharePoint site if you need the template. If you want any coaching or assistance on putting together your action plan, please reach out to Caleb or myself or Andy too, and we'd be happy to provide that, or Shannon too. And then our ask is that you upload your completed action plan into the SharePoint site prior to next week's webinar. If you are concerned that some of the content in your action plan is maybe a little sensitive, or things that you just, maybe there's a hospital in there, or something that you don't need everyone else to know about, that's fine. Just let us know, and you can email us that. We can keep the information confidential. But otherwise, we really encourage you to upload it into SharePoint. If you need help with figuring out how to upload into SharePoint, please reach out to Caleb or Andy as well. So the next week is the last call. If you have any specific questions or content that you'd like to be ensured that are part of that 6th webinar, please let us know in advance so that we can work with Shannon and make sure that information is shared. As always, with today's webinar and the one next week, we encourage you to use the chat box and certainly speak up during the webinar too. We're happy to field questions, and it's *2 to unmute or remute your line. And then lastly, as a heads up, in the webinar next week, one of the other things that we'll be asking you to do is to complete some polling questions. And this is about knowledge gain, and also a little bit about satisfaction with being part of the Learning Collaborative too. So just a heads up that there'll be some kind of to-dos in advance for next week with uploading your action plan into SharePoint, and then also the request that you would answer the polling questions as they arise. After the webinar next week, then Caleb will be working with you to schedule some wrap interviews for months down the road, and that will be time for us to, for him, Caleb, to have a conversation with you about what's going well with your action plan. What have you accomplished? What have you learned from it? Maybe a little bit about barriers and things like that too, but really it's a chance to shine the spotlight on the good work that you're doing and to offer a little bit of technical assistance during those calls as well. So they're relatively brief, 30 minutes or so. And so Caleb and Andy will be working to schedule those with you, and those, again, are months in advance. So with that, unless anybody has any questions about what to expect in the next week or so, we'll move forward with today's presentation. I'll turn things over to Shannon.
Well, thank you, Tracy, and we appreciate what the activities are going to be. Hopefully there'll be a lot of information that you've learned, and as Tracy said, if there's something you want to know or clarification, if you'll let us know before the next week, I'll be happy to incorporate that. Of course, I'll be participating on the webinar, and will chime in when I can help. So I'm really excited about seeing what we can get done next week. With that, welcome to week 5 of the Learning Collaborative 201 series. This one is called How to Win Under the Tyranny of Small Numbers, Collaborations, Coalitions, and Networks. What I would like to say first, as always, I greatly appreciate the National Rural Health Resource Center for all they do, and particularly being able to participate in this webinar series to support you in one of these 5 core areas. As always, the context of this course of the webinar series is that you understand components of healthcare transformation, how that affects critical access hospitals and rural health clinics, and then, as always, hopefully some tools and resources to help providers in your community and state engage in transformation. Today's agenda, I really wanted to take a different angle at what the problem is of, how do we handle transformation? What does it mean to rural providers? Looking at it from not why it's moving in the nation, but why the response in rural communities is what it is, why it's affecting us. And then hopefully I can bring to light some of the benefits of living under small numbers and then perhaps leverage the barriers. We're going to explore just briefly collaborations, coalitions, and networks, and hopefully all of that will make sense and tie together with the rest of the webinar series, which, as you've already heard at least 5 times, the first 5, so I won't make you hear again. Next week we'll try to bring it all together under the big picture, results matter, how to demonstrate worth, value, and quality. So I look forward to trying to connect all those parts and pieces for you. So the tyranny of small numbers, I've used this term for a while, and there's not necessarily technical term of tyranny of small numbers in rural health. You can look it up in their Wikipedia and a couple of other places, and it refers to an instance in engineering or in even some other science. But for me, there is an effect, and it has to do with rural providers' delivery and payment models are defined and are limited by the relatively small number of patients they serve. This creates the effect of low volume, narrow margins, and few options. All that together is what I would call the tyranny of small numbers. The result of this is the unintended consequence that in statistical terms, rural providers are outliers. And I believe herein lies the problem, the crux of the matter of why it is difficult and not made for rural providers to easily engage in transformation. So I'm going to dig into that for you just a little bit. So in statistics, particularly, an outlier is a data point that differs significantly from other observations. It could be due to variability in the measurement, or it could indicate an error. What I think is most important in this statement is that an outlier causes serious problems in statistical analysis. It affects assumptions, it affects outcomes of statistical analysis that make those using statistics take a great concentrated look at outliers. So an example of that is, a value that lies outside either is much smaller or larger than most of the other values of the data set. So for example, in scores 25, 29, 3, 32, 85, 33, 27, 28, both 3 and 85 are outliers. And hopefully that makes sense to you of how rural providers with low volume really are an outlier to the data set. They can range from being unimportant to very important. And I think this is the crux of the matter for us today. We are unimportant if we capture incorrect, inaccurate information, or we carry little weight in the analysis. That's two major points that I've been working on making all throughout this webinar series. One is inaccurate or incomplete or zero information, and then little weight in the analysis. The counter to that, it is really important if they carry a lot of weight or can give you important information that normal data don't. That's actually an opportunity, I believe. So let's see what that looks like moving forward. One other thing, when I was just digging out and confirming all these terms and definitions, I found this reference to this book that's called The Tyranny of Numbers, Mismeasurement and Misrule. The Tyranny of Numbers not only warns about the way the statistics are being measured or being misused in government policy in the United States and abroad, but it explains how this process can end up injuring vulnerable groups or distorting the workings of the democratic system. I have a funny story to share with you. So I'm very rural. I grew up 30 miles from a town, 5 miles down a dirt road. But in high school, I actually graduated third in my class. Now, in Texas, there's a standard that's been around for quite a while, and it holds that all public universities are holding slots for the top 10% of graduates in the state, so that you have at least a slot to go there if you're in the top 10%. I was third in my class, but I was not in the top 10%. I was third in my class, but I was not in the top 25%. I had 8 in my graduating class. So obviously, my school was an outlier because it's very, very small. I had less than 100 in K through 12. It's a number that's not meaningful when you're doing something on a percentage basis. You know, the counter and positive to that was every one of us that graduated had an opportunity to go to college because none of us were able to slip through the cracks, literally. It's hard to do that when there's small numbers. So this issue of tyranny of small numbers has been around for a while. And I think that it's important for us to note that, again, there's an opportunity as well as a barrier in this unique situation. So why does it matter? Why do we care about whether we are in the tyranny of small numbers or not? And the reality is, when we're looking at healthcare reform, both in payment and delivery reform, the entities that pay the claim, or insurers or payers, are seeking to control costs. As it's spiraling out of control, they're seeking to control costs. And in doing so, of course, they're using available data to determine their risk for predictable outcomes. And the result of that is when they do identify outliers, they could ultimately exclude outliers. And we can see this happening. This year, I think I mentioned this in one of my webinars earlier, but I spoke with a friend who's a leader in a large Medicare Advantage plan in the Northwest, and I called and said, so what can we do about, creating rural networks where they are easier for you to handle because they're unique and different? And she said, I'm not going to be rude, and she's a nice person, so she wasn't rude, but she was pressing me to hear what she was going to say. And she said, why should I care? Why should I care if you're an exception in your shape? I really care about value. Now, what's important about that is that Medicare actually announced that Medicare Advantage plans can actually do a lot more value-added services for their beneficiaries in order to get them to valuable providers, recognized valuable providers. In other words, they can use transportation as a result to bypass anybody that they think is not valuable and get them to a place that is valuable. And that's just one example. But, it's an unintended consequence, but it is actually happening before our eyes. What the counter to that for me, is while I was looking at this, I wanted to know, what is the size of rural in the United States? And I had a long belief that it was 20% of the population is rural. It's now 19.3, I believe. 97% of the land in the country is rural, but 19.3 live in it. That equates to still $60 million. 60 million people. So 60 million people we could be responsible for, but yet we are considered an outlier. So there's an opportunity. If we can collectively demonstrate our value, we have an opportunity to serve that others are not going to serve. We just have to figure out what the outlier game is. So thinking from a payer perspective, again, this is a slide that we looked at earlier on how they came to pass on looking at Medicare and figuring out payment models. But just from a high level, if you see this dollar and it's broken up into categories of how each penny is spent within the dollar on a premium dollar. And today it's at 81.8 cents for the medical budget. That's what goes out their door from premium dollars taken in to pay for medical services or prescription drugs. So they have to be able to predict very closely what their spend is going to be in that 81% in order to be able to pay the bills in the other portion of that dollar bill. This is what they're thinking of. They're not thinking about exceptions. They're not thinking about how far somebody has to go. They are thinking about where can I get the best bang for my buck for my beneficiaries. Where is the lowest cost and the highest value, and how can I get there in the most effective way? So from a payer perspective, managing the medical budget involves risk and risk analysis. Risk analysis requires statistics. Statistics, there are outliers. Because of the tyranny of small numbers, rural providers are outliers. Outliers could be unimportant or they could be really important. And I think for us in this call, we really need to consider how to make us as outliers become very important in the game. So the biggest barrier, obviously today, what I would see the biggest barrier for even participation in transformation is because we have low volume. We have low volume when we have low volume, we have very narrow margins, so there's not a lot of room to explore and diversify. When we have low volume and we need to get into a payment model and it requires a minimum amount of beneficiaries that are not in our group, then we don't qualify individually. There are barriers simply because we have low volume. So how can we actually solve that? And I think the good news is that I would say part of the benefit of the historical effect of tyranny of small numbers is rurals have thrived under changes in payment reform, previous payment or delivery reform that exists today that's an exception or different, and have become very astute at living under those. So I think it's really proof that there's great opportunity for rurals to see whatever the future holds and find a right solution for sustainability. Obviously here the payment models I noted were the all-inclusive rate, the dish payments, and cost-based reimbursement. The delivery models that we see here today are critical access hospitals and rural health clinics. We've seen some of those challenged in the recent years. I would say the last 5 years we've seen some of the delivery model challenged. We've also seen the erosion of the cost-based reimbursement simply because the way the payers are modeled under Medicare, Medicare Advantage and Medicaid MCOs actually fall off the cost report. It used to be all of the government reimbursement stayed on the cost report, and now it's adjusting. That in and of itself changes statistics within a rural hospital of what their basis of revenue is coming from, what the largest component is like revenue in the government side versus the commercial side. So you can see this effect in all places that we talk about in rural healthcare. I also came across the tyranny of small decisions, and I think that this is something that we need to hold close with the government and the rules that they're making. If we have a long-term vision, if we stretch out there and consider what we want to see as a solution of what rural health should look like categorically, then we need to know that the decisions that are made and that we accept and don't push back on really align with that. Otherwise, the small decisions ultimately come to a point of an outcome less than desired. Again, unintended consequences, but still something that I think when you are only 20% of a body of work, that the people that are working on it are consumed by fixing the 80%, that we are left with focusing on what can we do as a group collectively to create some consistency to become important. So again, that's what we're pushing toward. So how do we solve this problem? Are these problems, the new payment models, the issue of low patient volume and the issue of low data volume? And I believe one of the opportunities, probably one of the biggest and one that's well known in rural healthcare across the country, is collaboration, coalitions, and networks. So let's just talk a minute about each one of those. Coalitions are generally temporary, and they are formed for a short-term and narrow aim. It's not as formal, so it can be, again, for a short time to complete a project, or then it could be a short time to do a proof and then move on to a more formal relationship. Collaborations, however, are moving a little more towards formality. There are at least two or more parties that work jointly towards a common goal. There's also in this definition the idea of knowledge management, and I included this because I thought one of the most powerful things that I saw, I managed a network of 13 hospitals for almost 20 years, and that transfer of know-how among individuals was the least quantifiable, but probably one of the most valuable things you would see at a board meeting of rural hospitals on a regular basis. Having them come together, talk about what they need in shared collective, or what they could just share in this knowledge, was invaluable. And I don't know that we put enough weight on how valuable it can be on that knowledge share, but I would offer to you to take notice of that, because it really gives a pure community a lot of strength in the effort of sustainability in these changing times. And then the last one, even in negotiations, you seek advantages, you seek solutions that are advantageous to all parties. If you're in collaboration, you have more volume, so you have more strength. You have the ability to align horizontally and vertically ideas as well as participants. So all of these things really lean to how important collaboration is, either as a noun or a verb. And finally, networks actually are the most formal. They are a network of companies that work collectively to accomplish objectives. Generally, it's, in my experience, a new tax ID number that could be independent or could be equally owned by a group of providers, depending on how it's funded, depending on what the long and short-term goal is, would drive some of those opportunities. But I believe that in this need of volume, that one of these three, coalitions, collaborations, and networks, are the greatest opportunity for rural providers to be able to engage in transformation. A perfect example of this is the collaborative ACOs that several of the rural hospitals across the country under AIM funding participated in. Those ACOs were, of course, a payment model, but they also acted as a SIN and a network. Each of those providers that participated in that new tax ID had to sign a participation agreement, and they all had the opportunity to have governance in that. So they acted together as a network, as a collaborative, to accomplish the objective of having enough volume, enough infrastructure to be successful in value-based payments. I would suggest that you don't have to be an ACO to accomplish that same thing. And actually, ACOs could be short-lived. I think that they will exist, but the shared saving ones are transitional and will not always exist. So the opportunity doesn't have to, for rural providers, does not have to sit only in a payment model. It can happen outside of a payment model. And again, in fact, I did that for over 20 years, doing a network with collaboration to create group services, shared group services, perhaps some group purchases, and then some responses collectively that they could not have done independently. So I can't say enough about how important I think that the opportunity for network is. The other thing is networks really give the opportunity of providers to not have to seek financial alliances with urban centers that are not created and focused on the populations in rural markets the way rural hospitals are. So again, it's a great opportunity to participate in that way. This is sort of a summary of the opportunities. I outlined them in categories. So in volume, under this collaboration, coalitions, and networks, you can gain volume of patients, volume of data, and ultimately empirical evidence of the value. And this probably is the most important thing because of the chaos in payment reform today. Having the ability to have empirical evidence of value in order to negotiate with commercial payers is critical. And one of the things I learned in the last 5 years was that when you are looking at engaging deeply with commercial payers on significant value-based payment methodologies, they want to see 50,000 lives. And now 50,000 lives would mean, you know, a lot more than 10 rural hospitals. So this would mean significant collection. The issue to keep in mind when you do that type of negotiation requires clinical integration. And we did talk about clinically integrated networks last week. So that's a form of a network, a coalition, or a collaboration. It just gives you some legal protections and some data. The other thing is this infrastructure opportunity. So having the ability to share in technology, share in governance. In other words, you don't have to hire an FTE for you to get the job done. You can share in that hiring, or maybe share staff in some way, depending on who all's at the table. And then you might be able to actually complement on shared services by collaborating. This does, in this network, coalition, and collaboration, give you the vehicle to participate in payment models that you would not otherwise. And it gives you the perfect platform for doing that virtual and clinical integration, of course, then actually technically collaborating, having other people with boots under the table, as we say in Texas. And finally, the foundation of acting as an enterprise, which means you could equal in voice at your state or nationally. If you come together with enough empirical evidence of your value, you could act as an enterprise under an organization that's formal. That also counters then with the opportunity to still maintain financial autonomy as a rural provider. Huge opportunities in this idea. Interestingly enough, the opportunities and obstacles lie equally with what I mentioned, both in virtual integration and clinically integrated networks. There is cost in creating them if you go so far as create the formal network. There is new thinking required in order to collaborate. I would say one of the most interesting things when the network formed. I was there in the early stages. In fact, I was the first employee and stayed there 20 years. And when the formation happened, there was this huge resistance of having what was perceived as competitors at the table. And through good legal work, through good participation agreements and transparency at the governance level, the collaboration became very comfortable. In other words, they recognized they could be good competitors but better neighbors. And that lasts even today. That's been around since 1995. That organization is still in existence and under those same values. The obstacle is how big do you have to be to get the volume? Can you manage that in that collaboration, everybody getting on board for the same perspective? And I think something that from the Flex perspective, you would have an opportunity of creating a common goal and a common transparent governance in order to get some comfort levels for people to participate. There is infrastructure costs. The balance of the obstacle is an opportunity for those that want to participate to share in that cost. So I see that as a wash. The other thing, it doesn't have to be a payment model, and some people don't feel like they need to get into networks unless there is a payment model. I would argue that differently, because in reality it's going to be difficult to get into a payment model if you wanted to, and you're going to want to. So you should go ahead and start networking. So I've asked this question, I think, every week, and the question is, what is the rural option? I don't know that it's 100% clear, but I can surely give you my opinion. Early on in this series, I said, what are we thinking? We as rural providers think we provide a service and we get paid. That might be in question. It feels uncomfortable right now. What service do we provide, and how do we get paid? How are we going to get paid? Has that changed? What service do we provide? And by that I mean, are there opportunities that we can provide that we haven't before? And could we get paid? And would that payment be really, really significant enough to invest in and participating in that? We are thinking we are different, and that's good. I think we are thinking we are too small, and I don't think we're too small to be collective and become significant. The going thought across a large group of rural providers is that we are exempt, so we don't have to, and I think that could be one of those that falls in the tyranny of small decisions. If you choose that you're exempt and therefore you don't have to participate, it could be at some point a place that a point of no return where you aren't able to participate. So I think that the big question then is, why are we valuable, and how do we prove that value, not just to ourselves and our community, but to the collective thinking? How do we demonstrate that 20% of the country and 60 million people deserve the same health care that everyone else gets? Maybe they get paid a little differently, but statistically we are exceptionally viable. So again, the measurement of cost and quality, which equals value, resides in the data. And if you walk away with anything in this webinar series, I would suggest that you stay very focused on the idea that every provider should know what their value is, what their data is saying to everybody who's buying their service, what their data is saying to everybody who's buying their service. That's very different than when you do quality improvement in a hospital. Those quality days are hugely valuable and not to be discounted, but those are not measured by the payers. So those efforts must be connected to the payer community. And so that comes from data, because the payer community is measuring you on data sets they already have. And if you're not documenting in those data sets, then they don't see you as value. So I can't say enough about how important I think this really, really is. So the other thing is become statistically important. Again, collectively, I think that is very possible. I know that there are ways that we probably have done that before. Another example I can tell you is in 1997, Texas Medicaid put out a book every other year. Instead of publishing papers, they put it online, and it was called the Texas Medicaid Handbook. And you could look and see statistics of what was delivered, where it was delivered, what the cost was, what the projections are. And that book said that all of the 100-plus rural hospitals in the state of Texas only equaled 4% of the Medicaid budget in Texas. 4%. And McAllen Hospital, that resides on the border, by itself represents 5%. So you can imagine this idea of what I know is every single rural hospital administrator is as smart and as independent as any hospital administrator of any size. If each of them are all thinking differently, you become less than 4%, which is already the smallest component of any cohort in the Medicaid budget. So how do we collectively get all the rural providers to become somewhat significant? This, I think, is the big test for us in the future, is to become statistically important in the statistics game of this period, what I would say, of research and development for the new payment models that we're going to see in the future. I've said this slide before. We need to think about think about healthcare delivery also in a new way. So I've just touched on payment reform, but delivery reform really is asking us to think differently. We've seen for a while that perhaps longer stays in hospital are not the solution, that getting people out of the hospital and getting them home is a better solution. And we've seen that through payment model changes. You know, readmission penalties are certainly far and wide and affecting everyone, which then affects what would be the bread and butter of what the rural healthcare campus is. So if we have this bricks and mortar that are critically important, that reside in a place in rural America that really doesn't have a whole lot of competition in that geographic area, it can be leveraged to not just be heads and beds. And in fact, most critical access hospitals with rural health clinics are 75% ambulatory services anyway. So the idea of exploring the campus to be leveraging the opportunity of new technologies and the ability to even see the new types of collaboration that we see across the country. When we talk about vertical integration and horizontal integration and collaboration, we see crazy things like CVS, who lives maybe in a what they would call a healthcare desert of bricks and mortar, that became hugely important to commercial payers. That's an interesting model. Bricks and mortar in a place that there's a healthcare desert, and become critically important to commercial payers. I think rural providers could do that, but there's a couple of things that are really important, and that is an alignment and demonstration of the value of that system. Buying all of CVS was owned by one entity. They knew what their quality standards were. They knew what they were getting. They knew what they were not getting when they aligned with Aetna or United, I forget which one. So alignment of the value statement, and then being able to leverage that to create a platform and not just a product. The product right now is a clinic and a hospital. Let's take the campus that has a clinic and a hospital and leverage that to actually become a platform to provide health, value, and health and health care of the community. And I think we have every opportunity to do that, every capability to do that. We have to start with demonstrating data, demonstrating value in the data. This all ties to virtual integration, and by the way, this again was in the Managed Care Handbook, so actuaries have read this. I was at an actuary conference about a year ago and said, I actually read the Managed Care Handbook, and they went, oh, yeah, that's a great book. I didn't know anybody read it, but apparently actuaries do. And so they are very familiar with this idea of virtual integration. We just have to be able to act in concert with others. It's one of the barriers for rural hospitals, because we're of low volume, is that we don't have specialists, because you have to have a lot of volume to have a large enough small cohort of cardiology work to bring a cardiologist, obviously. So again, this is baked into what Medicare has already offered in the pay-per-value program, where they make the patient-centric and the total spend accountable to every provider that works for that patient that's in the center. It hasn't come completely out that you can see that, but ultimately it should roll to that you can see that providers who are being measured on cost and quality will want to only connect with other providers who are measuring on cost and quality, because the total group of providers treating individual patients comes out in the quality score. In other words, if a rural provider is not doing quality scoring and another rural provider is, and that rural provider refers it to another one, when the rural provider that's doing the reporting and scoring is measured, they take into account the total spend, and if that other provider is not doing the work of preventing duplication of efforts, duplication of tests, preventable readmissions, and preventable admissions into the ER, then that will affect the provider that's actually working on that. So there's going to be this divide of people within their own communities, within their own provider community, of which they're going to see they're not valuable based on the value measure of today. Doesn't mean that doctors aren't good or bad. It just means it's a value statement, and you have to get on that game. So with virtual integration, there's opportunity to go up and down the spectrum of the continuum of care, and also even go into the payer side. So there's opportunity there, and we're seeing that, but I think that first and foremost, we have to demonstrate our value. This, again, just as a slide reminder of vertical and horizontal integration. It could go into that virtual integration. By the way, you don't have to be clinically integrated to be integrated. You will be limited on claim sharing and value payments in the collective because of Stark and antitrust. But you could still be a virtually integrated system and get some work done before you get to the point of going clinically integrated. So there is options out there to start with or without clinical integration. So I'm going to leave you with this. I think I've beat the drum every week, and you're going to hear it one more time next week. But I can't say enough about how important it is that we know that how we all feel about rural health is clear in the value proposition that we're seeing in the country. So with that, I'm going to wrap it up at about 1/4 till, and I'll be happy to engage any questions that anybody might have, any comments, any thoughts about next week. And remember, *2 to unmute your line, or feel free to type into the chat.
Thanks, Shannon. This is Tracy. So my background is actually in epidemiology, so I love the concept of talking about these numbers and the impact that they can have and the scalability of it. So I just find it fascinating. Questions at all from the group? Or, yeah, you bet, absolutely. Questions from the group or things you'd like clarification on, something that stood out to you today? Okay, maybe something just to see how people are tracking on things. If everybody could use the chat box below, and if you could type in whether or not you, for your state, have an idea in mind of something to put in your action plan. So I don't need you to tell me exactly what it is that you have, but just, yes, I have an idea, or no, I need some help. And if it's no, I need some help, then we'll get in touch with you. Okay, looks like Pennsylvania has some ideas. Jeff, you need some help. Okay, so Jeff will be sure to reach out to you. I'm kind of telling Caleb that he's going to be doing this, but since he's leading the project, once he's back in the office here, I'll have him reach out to you about some ideas, or kind of walk you through what's it out. Looks like Wyoming's got some ideas. Yeah, you bet, Jeff. Happy to help out. And then the others to hear from would be Laura and John in Vermont, if you have ideas of things you're thinking about putting into your action plan. And Kyle, I see that you're asking for help too, so we'll get in touch as well. Okay, Laura, looks like you're looking for some help. And you've got some neat CCO activities happening in Illinois too, so maybe there's something we can kind of springboard off of there. And John, looks like you're not sure either. So we will get in touch with all of you guys and figure out how to help you out with getting a few ideas and things put into an action plan to kind of wrap up this activity. Before we kind of adjourn, and looks like a little bit early today, which is always fine, I think. Anybody have any final questions, comments for Shannon at all?
I was wondering if those of you that said collaboration and network, would you like more information about that next week? Excellent. I'll be happy to do some work on that for you and include that.
Cool. I guess into just seeing the names there, like Jeff, Kyle, Laura, and John. Caleb is, like I said, he's traveling back today. He's off the next 2 days. I'll send him an email about what we talked about here, but I think an ask of you, too, is if you have some things, just some ideas that are floating around in your head, please email Caleb. That gives him a place to start with the conversation. It'll just make your conversation a little bit more expedited so that we do get this wrapped up in time to be able to have a version of your action plan prior to the call next week. So kind of an ask of you for Jeff, Kyle, Laura, and John. Brainstorm a couple ideas, things you could take away from this learning collaborative, jot them down in an email to Caleb. And again, I'll kind of on the opposite side here, tell Caleb to reach out to you as well and kind of set up either a chance to either talk via phone or via